Okay, so I'm going to discuss the issue of endovascular versus open approach for multi-level disease from a surgeon's perspective. But I think regardless of whether you're a surgeon or a cardiologist or interventional radiologist, we all should share a similar perspective on this if possible. These are my disclosures. So I think that basal trial, which we all are pretty familiar with, randomized endovascular therapy versus open surgery for patients with CLI. And the initial results of the basal trial publication established endo first as an appropriate approach for many patients. Now, when we look at the patients living beyond 2 years, there's actually a benefit to open surgery with autogenous vein. So the initial publication basically showed endo approach first is probably the preferred for some patients, yet later publications showed that some benefit more with surgery. So how do we choose? I do think, though, this paper really clearly showed that there's a role for both. So reasons of favor an endovascular approach. These CLI patients are older, sicker, generally don't tolerate anesthesia well. Revascularization to the tibial level carries significant morbidity and more mortality risk. Life expectancy is short in these patients, so you really don't want them to be recovering for 6 months after an operation. Reasons favoring open approach is that CLI patients do not tolerate failure of revascularization well. You may only have one shot at it. Multi-level disease is obviously harder to treat than single-level disease, and you have multiple areas of potential loss of patency over time. So the relevant questions are the incremental cost of the perioperative morbidity of open surgery compared to endovascular intervention, the durability of your endovascular intervention, and if your durability of the endovascular intervention is not long enough to achieve your goal of wound healing, how many interventions will be required, and when do all those the risk of all those interventions add up to be more than that surgical risk. So those are the sort of things to think through, and I think that patient risk, lesion complexity, and wound severity really impact that, and I'll try to get to this if I can. So what is is there evidence to suggest that percutaneous intervention is even effective for multi-level disease? Well, there actually is. There's a fair amount of literature on this, and I'm just going to highlight a couple of them. So this paper looked at outcomes following infrapopliteal angioplasty for CLI, 450 limbs, and essentially the main findings is that multi-level intervention was not associated with an increased risk of restenosis or amputation. And these authors concluded that endovascular intervention is effective for task A, B, and C lesions. Task D lesions probably require a bypass because of the poorer patency in these interventions. In this paper of 123 limbs, they found that multi-level intervention was associated with improved wound healing compared to single-level intervention. And their conclusion was that percutaneous intervention is effective for CLI, even in multi-level disease. But certain predictors, there were certain predictors of bad outcome, such as end-stage renal disease, pedal disease, and isolated perineal runoff. And these patients maybe should be considered for surgical bypass, simply because these patients did not do as well with these percutaneous interventions as the patients without these factors. In this paper, 89 limbs in 85 patients. They looked at patients and stratified by the multi-level intervention versus single-level intervention, and found that secondary patency was higher in those patients with multi-level intervention. So primary patency is the same, but secondary patency was better in patients treated with multi-level intervention. And their conclusion is that their patency rates with percutaneous intervention for these patients are similar to patency and limb salvage are similar to historic surgical controls. Multi-level intervention is associated with a higher secondary patency than single-level intervention, and multi-level disease should certainly not be a contraindication to considering endovascular therapy. The same findings were echoed in this paper that also found time to healing was shorter with multi-level intervention, and again, secondary patency was higher. So the same conclusion basically is that adequate limb salvage can be achieved in CLI patients with multi-level interventions, and improved patency is achieved with multiple compared to single-level interventions. So is percutaneous intervention effective for multi-level disease? I think that multi-level endovascular therapy certainly do achieve good limb salvage rates and patency rates, at least secondary patency. Multi-level is probably preferred to single-level interventions. But there are some patients that have been identified that do poorly, renal failure, single vessel runoff, as I mentioned, et cetera. So how do we sort these patients out, and how do we figure out who these patients are so that we can identify those patients best treated with surgical bypass from the start? These are the factors I already mentioned that influence this decision: wound severity, patient risk, and lesion complexity. And there's been some work on trying to sort out which patients are at most risk of needing an amputation. The Wi-Fi score, which I'm sure most of you are familiar with, is a grading system for a wound. So it's not enough, I think, these days to just call a patient a limb threat patient or a tissue loss patient. We need to look at how big the wound is, the degree of ischemia, and foot infection, because these all matter and interplay with each other in terms of risk of an amputation. So the Wi-Fi score basically grades wounds, ischemia, and infection on 4 different levels, and that can give you a total of 64 different scenarios in terms of a clinical score or your Wi-Fi score. So this has been used for several years now, and this has been validated as a good predictor of limb loss. And the newest thing to occur with the Wi-Fi score, I'll get to here. These are the different 64 different clinical scenarios, and then based on the perceived risk of amputation, which was achieved by a Delphi consensus method. It's a panel of experts that basically rated these different scenarios. Anyway, they've come up with different scoring systems to put someone in a Wi-Fi clinical grade, and this is basically a low, very low, low, moderate, or high risk of needing an amputation. So the next step with this has just been recently published last week, actually, the Global Vascular Guidelines, which is a consensus between several different vascular surgical societies, which basically tries to approach an evidence-based guideline for deciding which patients require open surgery ultimately. It defines definitions and evaluation and workup of these patients, but essentially it takes the Wi-Fi score as well as other issues to kind of combine the degree of patient risk, and it doesn't just look at the wound, but also looks at other issues, which I'll get into real quickly. So the basic gist of this is you first do appropriate imaging, define a target artery path from the groin down to the toe, basically, or where the wound is, and then you basically use something similar to the task classification to get an anatomic grade. That anatomic grade is then combined with a Wi-Fi score to get your degree of risk of amputation, and to determine the degree of complexity of the intervention, as well as the likelihood of maintaining limb-based patency for that patient. So I won't go through this just in the interest of time, but just to say that once you have the limb severity in terms of the Wi-Fi score, the anatomic complexity, then you basically use this chart to determine which patients may be best suited with bypass rather than intervention. So multi-level disease can be effectively treated. When multi-level disease is present, multi-level intervention is probably the preferred route of treating the patient rather than hitting just a single level. And the decision to proceed with open revascularization is dependent on several patient-related factors, including procedural risk, wound severity, anatomic complexity, and is also influenced by conduit. And these new global vascular guidelines may help us with this decision-making. Thank you.